Alright guys, today we're going to be covering the objective examination for the lower extremity. So our objectives. First, we're going to define the role and the purpose of the objective examination. We want to clarify the idea of what is a comparable sign and the hypothesis generation that we're expected to do. We're going to call the SENS model and see how this drives and plays into the objective examination. Next, we want to explain the role of screening in this process for lower extremity, and then kind of examine the procedural flow, that thing that makes up the objective examination, and then break that apart and discover how it develops. And finally, we want to discuss the idea of what a physical performance measurement is and then the role it serves in our objective examinations. So what is the role? The role of the objective examination is using selected, deliberate tests to kind of confirm our hypothesis. Now, this hypothesis generation is going to be regarding the symptom mechanism, the sources and the symptoms, and the contributing factors. We want to put an emphasis on reproducing that patient's pain, that comparable sign they came through the door. And finally, at the end of the examination, we want to kind of have a confirmed hypothesis. We want to have 1 to 2 comparable signs and a guidance on the appropriate avenue to kind of take with our treatment. So the hypothesis, this is what should be formed at the end of the subjective examination. It can have many forms, but mainly it should express what are the sources of those symptoms, the contributing factors that are playing into it, precautions and contraindications, and the management that's going to withhold. Keep in mind too that the hypothesis doesn't just necessarily need to be pathoanatomical, it also can be treatment based. An example of this is the lumbar spine with our mobility or active rest or repeated motions. The comparable spines, the comparable sign. So this is a huge component of what we are trying to do. We want to reproduce that pain that brought the patient through the door. This is their pain, their familiar symptoms. Now, if a finding, within the area is painful or abnormal, but it's not related to this, you can call this a discordant pain response or a joint sign. Now, also, sometimes a comparable sign is known as a concordant sign. But the key with this is make it measurable. If they have knee pain with squatting, what is that measurement of what they're at in the squat? If they have pain with overhead reaching with 5 pounds, make it 5 pounds. See where that pain comes on, because we want to be able to test this, treat it, and then retest that measurement to see if we've improved upon it. So a joint sign. These are important. There are any abnormality found there in the clinical examination. They truly help determine those contributing factors and that regional independence, but sometimes we got to be sure that we don't run away with this. So always remember, correlation is not causation. A lot of times we can miss the side of the forest by staring at a tree, and a joint sign can seem as a contributing factor, but we can't necessarily say A plus B equals C. We have to do it in due time. Again, this is another time that a test, treat, retest model can come pretty in handy. So the principle of assessments. Before you begin any range of motion testing, begin in neutral. Do not examine through the clothes the skin is in. And it's important to clarify with the patient on where they're comparable, what is their familiar pain, or if we are reproducing their familiar symptoms. And if they are at a baseline pain, we need to consistently check back to make sure, are we affecting this? If we're not doing that, they might slowly go from a 2 to a 3 to a 4 out of 5 without us ever knowing truly what caused that, because it could be slowly ramped on by the things we're doing. So constantly check back about that. And finally, emotion is not cleared unless overpressure is performed. So the SENS model, this is another thing that really guides our objective examinations. So one thing it really does is it helps determine the willingness to provoke these various symptoms. And it will help us determine the amount, the volume, and the vigor of our selected test. Keep in mind that you never want to over-examine the irritable, or you never want to under-examine the non-irritable as well. So with the SENS model, not only will it determine our vigorousness, but it's also going to do our order. We want to progress from the least invasive to the least vigorous to the most invasive and most vigorous. An example of this, if we know for a lumbar spine patient that bending really sets on the pain and they stay flared up for a couple hours if they bend over as far as they can, we're not going to necessarily begin active range of motion. We might kind of work our way around it and use that to the very end, or even do those in unloaded positions based on that sense that we gain from our subjective examination. So here's the procedural flow. Again, your sense model will help determine where you put where, but for the most basis, this is the order you would follow during your examination. So observation, this is a huge component. This starts the minute they walk through the door. Look at it from a general observation standpoint. What is their general posture? When they sit there, how are their ankles, knees, low back, etc. When you're looking at the patient, examining what's the gross changes in their skin. Muscle contours, body alignment. Is one side kind of folded over where the other one's not? And also their willingness to move. How quickly did they pop out of the chair? How quickly did they sit down? Did they shift, etc.? You can also look at it from a localized observation. The area the pain is in, we want to take note of skin changes. We want to take note of swelling, the bony alignment, any wasting of muscles in the area, and also scars in the area as well. So screening, this is one of the big components right after observation that we want to perform. So why? Well, first, it helps us look at the body from a regional interdependent standpoint, and it helps us prevent that tunnel vision. It helps clear those body areas that could possibly refer to this area, and huge important, it helps screens for red flags that might be occurring. For the lower extremity, you want to screen up all the way to the lumbar spine. No matter what, even for ankle pain, etc., screen the way up to the lumbar spine. So the first question that we need to do if we're going to screen up to the lumbar spine, or if the patient has any lower extremity symptoms, is a nerve screening needed? Any symptoms below the gluteal fold require a neurological screen. So for those, first thing we'll do is reflexes. Here's the general reflexes that you would be testing. Sensitivity and specificity listed above. Your myotomes, you have general ones that we know is the hip flexion, knee extension, dorsiflexion, plantar flexion. But also keep in mind for our younger population, you might not pick it up because it might just be small nuances. So you can make it a little bit more functional. So for hip flexion, you can do a single leg sit to stand. You can do your walk on your heels, your walk on your toes, etc. And they might be able a little bit more sensitive to pick up those little changes from side to side. And dermatomes is a very important thing to look at. And generally looking at side to side. Again, remember that you want to screen skin and not over clothes. Upper motor neuron testing, very important in this population and with this lower extremity that we want to do. Babinski and Clonus are two of our most specific ones that will kind of look at everything. And then some additional sensitive tests: slump, straight leg raise, pain pressure threshold. This gives us a good neurological screening that we can take a look at everything and know, not only if there's something neurologically going on, but is there something centrally? Is there a sensitization thing going on? And these three tests can kind of help point us in some of those directions. Now, next, after our screening, we also want to rule out the lumbar spine. A general rule of thumb is it's spine till proven otherwise. So how do we do that? Well, first you take the patient through their general range of motion. You want to then take them through their combined motions and take them through all of that again with the overpressure. If you're still thinking something might be going on, you're well within your right to try out PAVMs. Go into those accessory motions all the way grade 4, see if it refers anything down. For joints to truly rule it out, though, you need overpressure, you need quadrants, and in additional, those PAVMs help really kind of screen it out to know nothing is going on. So after we kind of screened everything else, the next thing we want to do is just simply ask the patient, show me what provokes your pain. This really puts an emphasis on you listening to them, that you care what in their life is presenting and causing some of those symptoms. Again, do this based on the irritability and the SENS model, but this is a huge quality things that we can do for our patients. Now, some things that this can kind of serve is it serves as parameters for a comparable sign. Make this measurable. This is huge. If they can show you what brings on the pain and you can make a change to that objectively, it gets so much of a buy-in, so much knowledge that you're truly affecting their symptoms. Also, it helps reflect that perception of the patient that we care about what they say. And in addition, it can give you some ideas about maybe doing some differentiation testing or even some symptom modification testing in the objective examination to give you some more ideas of what might be going on. So for your active range of motion, your passive range of motion, again, we kind of covered this with screening, but you want to go active, then active with combined motions, repeated motions, overpressure with combined motions. That's the general flow you should have when you're looking at the motion of the lower extremity. And so here's an example of a hip motion with quadrant. The motions that you should screen are sent to the left. And the reason why you should do these a couple different ways is the hip is loaded, difference. Perfect one is rotation. If you're sitting versus if you're prone, that's going to affect the area of the hip that you're kind of engaging. So you want to look at this in multiple ways. With a quadrant, that is kind of the positions that you should be doing as you're working it, and that can give you a really good idea for kind of what's going on with this patient. For the knee, active range of motion, flexion and extension, absolutely. Passive, you go your flexion and extension in the quadrants. And another one that's often missed in this is tibial rotation. You can check this actively if the patient can kick it on. Sometimes they have a hard time doing so. But checking it passively, sometimes with our arthritic knees, this is a huge miscomponent. They live life out in that external rotation and never get out from that. You got to think they're constantly engaging that medial meniscus when that occurs, or that medial joint line. Sometimes getting them out of that can be a huge beneficiary thing to help reduce the pain that is occurring. So ankle motions, dorsiflexion, plantar flexion, eversion, inversion, toe mobility as well. Passive range of motion, you want to do all the above motions and actually add in some abduction and adduction as well. That will kind of screen all the motions of the ankle. So next, resisted range of motion when this is appropriate. Again, you want to do it in the cardinal plane. It should really help determine the deficits in the comparable sign. But keep in mind, if you do think of muscle, if you think it's a calf strain, it should be painful with resisted range of motion, and it should be painful in multiple angles. So if I test something isometrically, I want to do it in at least one other plane, if not two other planes, to make sure, because it should be, if it's a muscle, it's going to be painful no matter what angle you put in it. If it's only painful in one angle and never ever in any others, it might just be the joint loaded in that position. So again, make sure that this is testing the comparable sign and it's tested at multiple angles. So palpation. First, you need to ask, would palpation help confirm my hypothesis? It's good to keep in mind that the palpation is not a good comparable sign and does not lend itself good to a test, treat, retest model, just due to the subjective nature of it. But also remember that it's just not about comparable sign. We want to do some general palpation. What's the bony landmarks, the temperature and swelling? If we're looking from a red flag standpoint, arterial lymph nodes, oftentimes forgotten, but can give you a lot of phenomenal information about this patient. Also nerve pathways to see if there's kind of any sensitivity issues going along. So joint assessment, we must assess this based on the irritability level. So say we're assessing the lumbar spine and we're, that they're high irritability, I might go L1 through L5 at grade 1, and then I might go grade 2. Then I might go grade 4 into the grade 3. So I'm going to start going all through them one at a time. Why? It's because their irritability is so high. If I flare them up, everything's going to be like a false positive. We're not going to get a true information of truly what's going on here. The joint assessment, it should be used to look at the non-contractile structures as possible pain generators. So that's the key. So if you're doing a joint assessment and they're getting on pain, make sure that the muscles aren't firing at that moment. And again, look for the resistance you hit, any spasms, and also those comparable symptoms. So, joint assessment, what do we need to do in each joint? Well, here are the listed of the hip joints, anterior, posterior, direct, indirect, lateral, posterior, anterior, all motions that we should assess with the hip joint. The knee joint, again, anterior tibial glides, posterior teleglides, rotational glides, again, are huge into our populations, often forgot. And also remember that the superior tib fib joint, superior tib fib is a great joint that we often forget, but can cause a lot of symptoms as well. And here's a list of the ankle. We won't go through all of these, but this is, a really quick thing to check all the motions down the foot. Oftentimes you can just have feet side to side, check one, check the other ankle, check one, check the other ankle. And then a lot of times you're looking again for that comparable sign, but also on any joint signs. How does their subtalar move? How does their talar curl move? Does this make sense? How does the big toe move? That is something often forgot with our ankle patients, and we forget how much stress is placed on the ankle if we're not getting that proper toe extension. extension. So a good thing to kind of check with this population. So special tests, this is just a general guideline that you should look at with special tests. Keep in mind that special tests do have their place, but they're not a great place, and there's many, many that are flawed. You really want to look at the positive and negative likelihood ratios. Sensitivity, if that test is appropriate for that, should be pretty high. Your quality standards should be 10 or higher, and it should be truly a test that matters. Don't test something for test's sake, especially with special tests. Why? They're provocative in nature, so we don't want to bring on the patient's symptoms. If it's not truly a test that's truly appropriate at this point in time. So here are a few listed that kind of pass that criteria that we had listed. For a fracture of the hip or femur, you can have the patellopubic percussion, the stress fracture. For any type of FAI or labral tear, the flexion, internal rotation, impingement, Thomas test, all good tests. One big test that's very poor test, the Scour test. We often use that for FAI or for arthritis, but it's a very poor test and it shouldn't be used. Test for a tear of the glute med, Trendelenburg signs, a great test. Some greater trochanteric pain syndrome, the single instance for 30 seconds. Also resisted external rotation, a derotation test is good. Chronic groin pain, bilateral adductor test, squeeze test, single adductor test. For IT band syndrome, Ober test is actually a very, very poor test. There's no reported values of this test. If you're looking at one for this, Noble's a little bit more supported in via research. For the knee, the meniscus, joint line tenderness is really, really important. For the meniscus, McMurray and Thesleys are the next kind of supported. While this is not on here, special test is just a test that you do. Your quadrants should play a huge portion into your meniscus. So it should be painful with overpressure and flexion extension. If you don't get it, try the quadrants as well, and you can sometimes reproduce that pain. Patellofemoral cluster, generally pain with resisted knee extension, squatting, or any parapatella palpation. For the ACL, Lockman is the best supported. MCL and LCL, varus and valgus. For the PCL, posterior jaw. And then finally for OA, there's no specific test. There is the Altman criteria. But keep in mind, too, when you're testing through these, it's generally we'll go through a couple. The Lockman is a poor test in your OA patients because there is laxity and reduced joint space. So, you might think you have a positive ACL tear for this population, but it's truly not. It's just due to the shortness of space. That being said, don't discount it. It actually can give you some good insight on the knee and know that, you might have a little bit of play here, etc. So, while I might not tell you about the ACL, it does tell you a little bit about the knee. The ankle, for any lateral ankle sprain, here's kind of the test listed. High ankle sprain, again, people are translation test, squeeze test. Achilles tendonitis, the Royal London test is really good. For any anterior ankle impingement, for dorsiflexion, tarsal tunnel, Tunnel's, stress fracture, the web space tenderness, Morton's test, or even the tuning fork. All right, so physical performance measurements. This is an observed functional task or a group of tasks that is measurable. It can show you change for your outcome and even serve some predictive purposes for risk of falls or risk of disablement, etc. What's good about these are a little bit less influenced by pain, and so much of our tests are focused on pain. This kind of pulls you out of it. And it's got a lesser influence of psychological factors and cognitive impairments, which can kind of result in some recall biases. So let's look at the hip. The 4 that are really supported, first is the timed up and go, your 40-minute self-paced walk test, your 30-second chair stand, and your stair climb. So the tug, we've often done these 3 miles, getting up, walking around, coming back. Really good for your aging population, your OA patients, your low back pain, and your fallers. In short, anybody with mobility, balance, or strength issues, very great test to do on. Your 40-minute test, of course, most of us in the clinic don't have 40 meters, while this test is 10 marks. So you mark 10 meters away, return there and back 3 times. You time it, and then after a series of time or for re-evals, you remeasure and see is there a significant difference in that. 30-second chair stand. This is basically arms across chest, getting up and down and out of the chair as much as you can within 30 seconds. Really appropriate for our elderly patients or patients with hip and knee OA. Can be a big factor too, because oftentimes these patients, this is their biggest limitation. So if they see they can go from 4 chair stands to 10, well, that's significant. It really shows value into what you're doing. So listed below is kind of a functional performance testing in athletes. Performance for the hips is often focused on the OA or elderly. I want to toss this in here to show you that, for our athletes, there is some functional performance testing that's valid and really good. The example of this is your single limb stance, your deep squats, your single leg squats, and your SCAR excursion test. One thing I would say about this is while these aren't necessarily, what we talked about, they're less involved with the pain, be cautious with your deep squat for your hips. Really know their irritability and what brings it on, because if you deep squat right off the bat with a hip patient, you could set off your irritability pretty bad. So be a little cautious of that. So your knee physical performance measurements, your stair test, your timed up and go, which we already talked about, your drop landing test, and your hop test. So for the stair test, it's just simply what it is. You ascend and descend 10 stairs as quickly and safe as possible. Really good for your aging, your cardiopulmonary, your OA patients, your low back patients. Pretty much in short, anybody that has mobility and endurance issues. Now, say you don't have 10 steps in the clinic and all you have is 4. Well, that's perfectly fine. Use that, but you want to use it as kind of a test, treat, over a course of a series of visits and then retest model. So drop landing. This was kind of convised because we want to know what components contributed to ACL tear of the knee. The problem with this study is there was no reliability nor responsibility reported, but the idea was it when you see it. And it was just say, hey, what are the knees doing, and do they have that valgus? So you're basically asking, is it good, is it reduced, or is it poor? And the beauty of this study is it did capture 88% of those within 1 standard deviation with valgus. So you kind of looked at it and said, oh, that's not good, that's the problem. So good, reduced, or poor. Hop test, good thing to know that these are often done in combination. You just don't usually do one. And there's multiple ways you can do it. You can do a single hop for distance, a 6-meter timed hop. How long does it take you to go 6 meters? How far can you do triple? Can you do crossovers, etc.? It's very valid in ACL and corresponds well with your general rate of change in your LEFS. All right, so for the foot and ankle, there's a couple of different ones that we haven't talked about. Your T balance test, your STAR excursion balance test, your Y balance test, and your hop test. Key is all these are kind of balance and multiple dynamic movements. So your T test, it's really just that. You're making a T out of cones, and you're going down, going side to side, and coming on back. There's worse scores noted with chronic ankle instability, which makes sense because you need a lot of ankle dynamic proprioception in this. And the responsiveness that we would expect is scores to improve after treatment. Y balance test, one thing we listed was the STAR excursion test. It's simply the Y balance is the STAR excursion, which is only 3 points. Here's a picture of someone doing that motion. The scores are, generally worse with chronic ankle sprains, and we expect the scores to improve after treatment. One big one to do this is the patient should do it slow and steady and not push it, but just glide it along and stop when they can't go further. And then finally, again, what we talked about, the hop test. We know the hop test is very valid in ACL patients and knee patients, but it's also very valid in your functional ankle instability as well. So for the summary, the objective examination, it's using deliberately selected test procedures, and that's the key. It should be very deliberate. You should have at least 2 reasons for every test that you've selected to do, and that's not just special tests, that's range of motion, reflexes, neurological screening. All that should have at least 2 reasons. It should be based on your hypothesis generation. If 3 of your hypotheses don't have muscle on them and you're doing resistive range of motion testing or resistive manual muscle testing, why? And that's what you got to answer, because you should not ever not be able to answer that question, why? Irritability will really help guide your order of flow and help you kind of know exactly what to do and when. Look for 2 to 3 comparable signs. Don't just be one and done. Look for 2 to 3 because, I mean, if you're making a huge change with 2 of those comparable signs, that patient is going to know that you're the right therapist for them, and most of all, it will help confirm that hypothesis. And then you can confirm that hypothesis with going to the test, treat, retest model. And finally, know that that physical performance measurement, oftentimes we don't do it, but it's observed functional task. It's something that is meaningful to them. Timed up and go. Most patients will see, oh, I see why this is important. A lot of our elderly patients have to get up and go quickly to the restroom. They can make that connection. And when they see themselves improving, they know that they're at the right place and you're the right therapist for them. Thank you so much for listening to this. I hope this clarifies some guidance with the objective examination in reference to the lower extremity. I really hope it kind of guides y'all to exceeding your patient's expectations. Thank you.